So the first case is a 70-year gentleman who had come with bilateral flank pain. He had fever, vomiting, and pain was more on the right side when compared to left. And he's been a diabetic for past 10 years on insulin. When he was attended first, his BP was on the lower side, and he had high-grade fever. We did an ultrasound, and both the kidneys had multiple stones, probably a Staghorn calculi on both the sides. When the laboratory investigations were done, his hemoglobin was 9.2, counts were raised, sugars were deranged. He had renal failure with creatinine of 7.6 milligram and urea of 114. Uric acid was also elevated. His urine routine and culture showed E. coli, which was sensitive to meropenem. This was the plain CT KUB, which we had done. Here you can see bilaterally there are Staghorn calculi, and there's some air pockets which are seen on the right kidney. Again, on the axial view, we can see some air pockets with bilateral Staghorn calculus. The Hounsfield unit of the stone on the right side was 1410 HU, and on the left side it was 1170 HU, and bilateral stones were present in the kidney with right-sided Wang-Sain class 2 EPN. So Dr. Subnis, we'd like to start with you, and I want Dr. Otas to join, please, and you may ask questions to the faculty and continue with the discussion.
Yeah, so the first question in a situation like this, I would like to ask Dr. Otas, that what would be your way of decompression? Obviously, this patient requires a decompression. Now, the whole discussion and the debate which is going on across the board is to DJ Stent versus PCN. So what is your choice in a case like this?
Well, in this case, we have to be very careful because we have bilateral Staghorn stones with severe infection caused by multi-resistant bacteria, which is sensitive just to meropenem. So I think we have to treat this case both by diagnostic, but also preparing for a future treatment option. And I would, in case like this, propose a PCN as an initial step in treatment, because in that way we can also create more PCNs in aim to prepare for multiple tracts, as these are complex stones which cannot be solved by just one access. And I think in this way we could solve.
Your choice is a PCN because same track can be utilized subsequently for the PCNL, and obviously because of the pus and other thing, it will drain properly. The related question to that which I want to ask you is that suppose this stone was at TUJ, a stone which was eventually amenable for the subsequent RIRS, and the patient has come to you with the same findings of the suspected pyonephrosis, some air pockets. Would your choice would have been different than the PCN, or you still would have done PCN rather than stenting? If subsequent treatment you would have managed by the RIRS. So what would be the choice in that case for decompression?
Yes, these days there is a huge debate ongoing whether to drain by stent, or even sometimes ureteric catheter, or to place PERC PCN in aim to, and there is a lot of favorable factors in direction of stenting, despite of placing the PCN. In the cases with we have to come to every case individually and to see what are the risks and what we want to achieve. If we want to have a good control of infection, maybe sometimes we have to be more aggressive. Right. And I think I am afraid that this case needs our aggressiveness in aim to achieve effectiveness.
Okay. Now, one last question I want to ask Dr. Amelia is that if you are suspecting if there are air pockets, does it really change your the method of decompression, or it does not matter at all?
I think it would.
Air pockets.
I think it would, because it's a sign of a possible gas-formating bacteria, and therefore it would indicate emergency. and that an emergency decompression would be paramount to clear the infection, because probably the system is so obstructed that otherwise the antibiotics alone would not be able to do the job and clear the infection. So I would suggest, as has been said, to put a nephrostomy and treat aggressively with the selected antibiotics.
I think just to summarize what discussion has taken place, that in a case like this, when you have the air pocket suggesting the emphysematous pyelonephritis, you have the Staghorn stone, you are having the high count, very high creatinine, I think best would be to decompress by PCN, and the DJ would not be the choice as per the experts here. So that I think is the outcome and the advice of the experts. Can you go ahead with the case?
Yes, sir.
Yes, if it is possible, just one little additional comment. Maybe in these cases, we can perform PCN under X-ray control and create access for a future PCNL treatment, because in that way we will create a tract which will be epithelialized, and when we proceed with the bigger area of the unclot sheet, the possibility of opening the vessels and going and the bacteria entering the circulation will be less. And I think in this way we can prevent septic intraoperative complications, because here we can have infected stones.
Dr. Pal wants to comment.
Yeah.
It is even puncture of the renal capsule, whether you get the pus or not on the right side, but just puncturing the renal capsule helps a lot in decompression, particularly in emphysematous pyelonephritis. So undoubtedly the drainage is better with PCN on the right side. Regarding left side, I am doubtful, because managing, you don't know how long you are going to leave the PCN tubes. Managing bilateral PCN becomes very difficult, and maybe the left side is not so greatly infected at present. So I will put a ureteric catheter and aspirate and see from the left side. If there is a clear fluid, I will leave a DJ stent on the left and do a PCN on the right.
So I have a question to Sabni sir. Once we do the PCN and decompress, do you wait to clear the stone during the same admission, or you give them a time and ask them to come back later for the clearance?
Yeah, so it all depends on how much is the output, how much rapid is the decrease in the creatinine, because he has got a 7 creatinine. His counts are high. So once you put a bilateral PCNL, we would put bilateral PCN. So once you put bilateral PCN, you also would know that how much is the output from each side, how the pus is getting cleared up, how much is the rapidity with which the creatinine has fallen. And if everything is fine, if everything is favorable, then we don't have to send the patient in the same admission. We can go ahead and do PCNL.
Okay, thank you, sir. So let's go to the next case. Here we have a 56-year-old gentleman who had come with bilateral flank pain, more on the right side. When compared to left, he also had nausea, vomiting. He had history of urolithiasis in the past and had a URSL done 6 years back. No comorbidities. When we did an ultrasound, he had mild hydronephrosis on the right kidney with a proximal ureteric stone of 12 mm. And on the left side, there was a partial Staghorn calculus involving the lower and middle calyx. Laboratory investigations were almost normal. There was no rise in the counts or creatinine, but uric acid was elevated. Culture was negative. This was the CT image where you can see right mild hydroureteronephrosis with the stone in the proximal ureter, or on the left side there is a partial Staghorn calculus. And the Hounsfield unit was 894 on the right side, and on the left side it was 935. Over to you, sir.
Yeah, so here, Jishan, one thing, what's the creatinine of this patient?
Creatinine is normal, 1.13.
Normal, and both sides hydronephrosis. Okay. Now, the one question which I want to ask, I think Dr. Bhaskar also is here. Bhaskar is left or he's still there?
No, I'm here. Sorry.
So, Dr. Bhaskar, one question which comes to my mind, and I want to ask all the experts here, is that when you have the patient like this, is NCCT your investigation of a choice, or it's a CT IVP, especially when the creatinine is normal? Because most of the guidelines, they show that if the kidney is all right and if there's not much hydronephrosis, then the choice is NCCT. So what is your opinion about that?
I personally don't insist on a urographic phase unless it's going to change my management or unless I'm worried. I mean, in this case, the right side, it's a mid-ureteric stone, upper ureteric stone. It's not going to change my management. On the left side, the only time I might want to do it if the anatomy is in question. If the anatomy is not in question, then we don't normally do it. The only thing that we sometimes do it is if you're not sure, especially in partial or full Staghorn, is if you are suspecting the kidney function. So you might need to want to do a renogram to look at the split function of how much this kidney function is. But I won't insist on a urographic phase normally, especially in this case.
So additional question to that, that's when do you suspect there is a problem in the anatomy? Because you have a patient whom you have done sonography and you have suspected a stone. So now you have to decide that what is the abnormality, whether there is any abnormality or not. So that's the time where you want to advise whether it's an NCCT or CT urograph.
So as you say, if the renal function is okay, and if you suspect, sometimes it's very obvious, it's anatomically, it's a horseshoe kidney, or if it's a pelvic kidney or something like that, then I think it's good to know what's happening, and any extra detail is helpful in avoiding complication. In a straightforward case, unless there is an overlap, so, you think that the bowel is quite close by, or they had previous surgery. If they had previous surgery, especially PCNL or open surgery, sometimes we have a low threshold for urogram. Generally speaking, I would say 5 to 10% of all our PCNLs would have urographic phase. So the answer to your question is almost very rarely we will do urographic phase.
Okay. So the question next is
Bhaskar, friend, can I just make a comment on this?
Yes, please.
Because I think it's we need to clarify something, because we say also in the guidelines that a contrast urography will be needed before you treat a stone case. But what we actually mean is not necessarily a CT urography beforehand. You need the contrast even as the retrograde form during the PCNL. So you need to identify the PC system in a way. I agree with Bhaskar that you need to do it preoperatively in those cases that seems to be peculiar for some reason, or let's say you suspect that is a calyceal diverticulum or an anterior calyx or previous operations, etc. However, before you do the operation, either ureteroscopy or PCNL, you have to identify the PC system, and you can easily do it in the straightforward cases by the retrograde urography, the first step of the PCNL or the first step of ureteroscopy. Just to clarify this issue, because I think we always perform urography prior to the operation, as I said. It doesn't matter if it is beforehand, like a CT urography,
Yes.
Either you in the past or you do a retrograde during PCNL.
Right. Dr. Otas, how would you treat this patient? Would you treat both at a time, or you will treat one by one, or which one you will treat first, or you treat both, not in the same admission, but in subsequent admission?
Yeah. I think it's clear that with the ureteric stone, we have to treat first right side. What is interesting here is that we have 800 calcium units and uric acid stone, so even hemolysis could be an option in patients with uric acid stones, but we cannot use hemolysis when this is obstructive ureteric stone. So first of all, there is a need to perform desobstruction on the right side. If there is no obstruction, we can go straight forward for the ureteroscopy and treatment on the right side. Or if you want to be less aggressive, you can do pushback of the stone into the kidney and then perform less aggressive way of treatment. But if it is ureteric stone, if it is uric acid stone, and if the stone is in kidney, we can also perform shockwave under the ultrasound. So there are more options, and we have to select the best one in every particular case.
Dr. Andreas, you talked about the recurrence and the uric acid and various other things. What are the indications for the chemolysis? Ota said that if it was a non-obstructive stone, the small stone you would have treated with chemolysis. Now, do you practice chemolysis? What is your experience of treating uric acid stone with chemolysis, and what regime you follow?
That's a very good question, actually. For I think the only indication that is currently being in use, let's say, for chemolysis is uric acid stones currently. So oral chemolysis is really a must, and we always forget about giving alkalinization for these cases, because we always prefer, as urologists, to do a ureteroscopy and get rid of the stone. You can do chemolysis also with by putting a stent if the stone is big, and you can also wait and avoid intervention. However, it takes time, approximately 1 month for 1 centimeter stone in size. So you have to have a patient urologist and the patient also, because it takes time. Having said that, we have to take it from the indication, and the treatment really depends on the indication, as you said. If you have some fever with the stone, then everything is the practice can be different. But I strongly believe that we are missing the dissolution therapy, especially for uric acid stones, because we prefer, all of us, the quick solution of a straightforward ureteroscopy. Regarding the dissolution therapy of other stones, percutaneous chemolysis, it is very rarely nowadays used because of the side effects they do have. And we have to consider, though, that the side effects and all the chemolysis background, scientifically, comes from studies back in the 1980s and 1990s. So we may have, as urological community, to re-see the percutaneous chemolysis to identify those cases. Let's say we all know that infection stones are very imperative to clear the kidney from every single fragment, which really can be very difficult for a complete Staghorn stone, infection stone, to do it even even with multiple punctures of the PNL. So I think in these cases, although very difficult to do it, I think it's going to be a little bit of space for percutaneous chemolysis. We need to do more studies up to date.
Okay. Jishan, you can go ahead with the subsequent.
The third case is a 50-year-old male. He had come with left flank pain. There was no fever, nausea, vomiting. He had history of alcohol consumption for almost 20 years. And both his kidneys were shrunken. Right side, it was 18 to 5.5 centimeter with the 1.5 centimeter calculus in the pelvis. And on the left side, there was a 1.2 into 8 millimeter calculus in the lower pole of the kidney. His laboratory investigations were normal. No urine culture was negative. So this was the CT image. You can see a 1.8 centimeter stone in the pelvis with 3 small stones in the lower calyx. And on the left side, there is 1.2 centimeter stone in the lower pole, and mild hydronephrosis was there on the left side.
So, Dr. Otas, now what is your approach in a case like this?
I believe this is a perfect case to emphasize what Bhaskar and Andreas previously made a comment on is contrast study, because if we want to emphasize and see what is the reason for mild hydronephrosis on the left side,
that's the important point.
that definitely won't be the stone in the lower pole, because it's not a non-obstructive stone, and we have to see what is the reason of obstruction, mild hydronephrosis. And I think definitely in this case, we need contrast study prior to the decision how to treat left side. On the right side, I think more or less it is clear, but from the point of view how to treat the left side, I think we should perform additional diagnostics on this patient.
So Dr. Bhaskar, you agree that this is a case for the contrast study because it's a lower callaceous stone, and you would like to know more details about the anatomy, which can be done only by contrast, to decide whether you are going to go for which modality of treatment, because you have so many modalities available.
I think, again, I have to agree, yes, you might decide, but I put into context what the patient wants, how old are they suitable treatment? Because if it's so on the right side, I would say, yes, you need to treat. On the left side, it's a lower pole stone. Observation might be an option if they want to. But I am, as Uta said, why is there some hydronephrosis? I'm not expecting that, do they have a structure, what is going on? So for that reason, I would like to have it, but not necessarily always for the stone reason.
Okay.
If they are happy with observation, then I may not do that specifically for that.
If they want intervention, then you have to decide
Yes.
whether it is going to be for RIRS, whether it is appropriate for PCNL, mini-perc. So in that case, would you like to know the details, or you decide only on the...
So in a standard case, just for the low pole anatomy, I have to agree, I don't do it. And the reason for that is up to 1.5 centimeter, I would always try a URS first, even in the lower pole. Beyond that, I would counsel the patient, and then mini PCNL would come to my mind for specifically lower pole, but I won't automatically do a contrast study.
Dr. Pal, how would you approach in this case? This is a 8.5 centimeter kidney, 9 centimeter kidney, but creatinine is all right.
In this case, to me, the left kidney does not appear to be healthy. Probably it may be, and the stone also, the appearance wise, it does not look like, it looks like an infection stone or some metabolic stone. So particularly for a better functioning right kidney, I presume I must do something for the renal pelvic stone on the right side. So certainly I will go for a whatever technique is best in my hands. I will do a mini PCNL and remove the right stone. Left side studies have shown, if you just follow these patients, 70% of the lower polar stones in 2 years of time, they become symptomatic and they need some treatment. So certainly we should manage the left-sided stone also, but at a later stage. First I will manage right side, and secondly left I will see later on, maybe after 2 weeks.
All right. Jisan, you want to bring out some more points?
Is there any role for ESWL in this patient?
I think
Well,
Vimal went away. Otherwise, let us ask Amelia.
yeah, well, in COVID time, it can't be excluded as an option. Consider you would like to prevent your patient having GA or maybe 2 operations under general anesthesia. But this is quite a large stone, is borderline for lithotripsy, but you can consider the right pelvic stone being in a good position to attempt at least 1 or 2 sessions of lithotripsy and see if it has some effect, because it has a higher possibility of likelihood of passage of fragments being in the pelvis rather than the one in the lower pole, which is more unlikely to for the fragments to pass. So I would attempt it, yes, in consideration of COVID time mainly.
Okay, so I have one question. Okay, Dr. Pal wants to say something.
Regarding CT urography, I tend to agree completely with Bhaskar. In the previous case also, who was a 46 years old male, there was a right ureteric stone. Now, if the CT urography you do, and even if the kidney appears to be non-secreting, non-visualized, still I am going to go for a ureteroscopy for that case, even if the CT urography says that it is non-visualized. So the treatment policy doesn't change whether you do a CT urography or you don't do. The previous case, if you see, the anatomy was very simple and clear. In 4 films which you have shown, everything is very clear. It is a normal anatomy. There is no malrotation, nothing of this sort. So I will restrict my CT urography neither in the second case nor in this third case. It is not going to help me in any way. That is what I feel.
So I have a question to all the faculty. If you have to go in, not this case, if there is a partial Staghorn in lower and middle calyx, if you have to go in, which is your ideal calyx? Which puncture do you go for? Which is your favorite calyx and why?
The favorite calyx would be where you can clear the maximum stone burden and you can enter from one calyx to other calyx. So that would be, I think it is not appropriate to just have a fixed notion that I will always go through the lower calyx, middle calyx or upper calyx. It is the calyx which is through which you can clear the maximum stone burden. That would be the preferred calyx for the large bulk stone.
Like for the previous case where we have a partial Staghorn, I'll show you the image. What would be your approach?
So in that case, I think the middle calyx is not visualized. The lower calyx is completely filled with the stone. So I would go with the middle calyx, clear up the pelvic stone, and from with the little angulation, you can go and clear the lower calyx stone. So that would be the approach.
Dr. Pal?
If you draw 2 lines from the middle calyx and lower calyx, they are interacting at 90 degrees. So if you go from the middle calyx, it is not the little angulation to reach to the main bulk of the lower calyxal stone. I always see where the main bulk of the stone is. Draw a line. If you draw a line from the lower calyx, the whole stone from the lower calyx, the whole bulk of the lower calyx, as well as about 70% of the pelvic stone. Everything can be removed through the lower calyx first. Once you have done the debulking, you have removed the stone, you just puncture the middle calyx and push this middle calyxal stone into the mainstream. And then there is no need to make another track from the middle calyx. That is a very small stone that can be pushed with the help of saline. It will come in front and can be picked up. So my choice will be to go through the middle, through the lower calyx in the straight way, remove all the calyxial as lower calyxial as well as pelvic stone, then give a saline push to the middle calyxial stone.
Yeah, Dr. Otas?
Bhaskar has also the comment, but I will be very short. I think not necessarily the optimal calyx for access contain the stone, because sometimes we can select the lower posterior calyx, which can make good access to the renal pelvis, but also to the anterior part of the lower calyxial group. So in that way, we can create and have access with less torque on for approaching to the renal pelvis, but also to approach to the anterior calyxial part of the stone. So not necessarily we have to puncture the stone if we are trying to create the optimal access. That's why I insist on retrograde pyelography prior to puncture, because I always create under ultrasound and dependent on X-ray or NCCT. I have a plan, but definitive plan is always in the OR.
Any last comment, Amelia?
I think this, in this case, a lower pole puncture could be difficult, mainly because we also always prefer to try to put the guide wire through the ureter, so down to the ureter. And in this case, because the lower pole is completely obstructed by the stone, I guess this could be difficult. So I would personally select the middle calyx and then try to clear everything from there with a guide wire in the safety position and a safe way to dilate the calyx. But this is my personal opinion.
The latest comment was not on this particular case we are now having on the screen, but generally. So it is for this particular case, I agree with Paul about the access. But if we go to the previous case where we had on the right side, you can see that sometimes lower pole puncture can collect both renal pelvis and calypsal stones.
Amit, may I make a comment on
Yes,
this?
sure, Professor.
Because I think we have to give some rules to the people that they are following us today. Amelia she's right actually in 50% of the cases. And what I mean is it really depends, the selection of the calyx is not a straightforward answer to your question. I think it depends on two issues. The first issue is what Amelia said. If there is enough space for the guide wire to be driven down to the ureter or to the pelvis or to the upper, just inside the PC system in a safe way. So the occupation of the lower pole calyx, let's say, by the stone is imperative. But the other issue also is the anatomy of the lower pole group of calyces, because you have to remember, just to give you an example, that the lower pole is drained by different and multiple infutibulums, where the upper pole calyx is drained 100% of the cases by a single infutibulum. So for those who are experienced with upper pole puncture, they always realize that although it will be difficult because of the pleura, because of the ribs, then the guide wire most of the time goes very easily down to the ureter or down to the pelvis. So I think the anatomy should guide us. If you are seeing from the CT scan or from your retrograde that is a very complicated lower pole group of calyces, then you should avoid and you should go through the middle calyx. And remember, you don't always have to torque the rigid instrument. You can use a flexible scope to reach the stone in the lower pole. So I think it's very important to keep in mind that two things are very important to selecting the calyx. First of all, whether there is enough space, the stone leaves you a space to go inside, and the second thing is the anatomy of the calyx.
Thank you, Professor.